Hello, I am Dr. Keith Burke, Professor of Behavioral Sciences in the Alcohol and Other Drug Studies program at San Diego City College. The AODS program is a fully accredited college-level coursework program that's designed to train students in the required coursework needed to become a certified alcohol and drug counselor in California. Today, I'm going to talk about clinical work and a little bit about relational dynamics. The concepts introduced in this lecture are usually used as an introductory lecture for our family counseling course in the AODS program, but the clinical concepts will apply to working with individuals, families, or groups. Let's talk about some definitions so we have a clear sense of what we're talking about when we're talking about clinical work. So a patient is considered to be any recipient of healthcare services which is performed by healthcare professionals. A clinic is a healthcare or a hospital setting where patients are given medical treatment, especially of a specialist nature. So an example of that would be a substance use treatment clinic in which you have a healthcare setting that people are getting medical treatment related to a substance use disorder. Clinical simply means it relates to the observation and to the treatment of patients. A counselor is a person who is trained to provide assistance and guidance with personal, social, or psychological problems, and it's often used as an umbrella term for both licensed clinicians with advanced degrees and for those offering other forms of counseling. A clinician is a healthcare provider who has direct contact with and responsibility for patients, and it's a person who's qualified to conduct clinical work in a specialized practice. So, for the purposes of treating substance use disorders, a substance use treatment facility is considered a healthcare clinic, which provides specialized healthcare services for patients who need treatment for a substance use disorder. An alcohol and drug counselor who's providing services to patients, which are typically referred to as clients in the field, but patients, clients mean the same thing. So an alcohol and drug counselor who provides services to patients in a substance use treatment facility is considered both a counselor who's providing assistance to those patients and a clinician who is somebody qualified as a healthcare provider who's conducting clinical work in a specialized practice. So patients or clients in any clinical setting or any formal healthcare setting are typically presenting with more severe symptoms than those that can be addressed by the person alone or with non-clinical support. And equally, a person who enters a substance use treatment facility typically has developed moderate to severe symptoms from a substance use disorder that the person can no longer control in spite of negative consequences, and it requires specialized interventions from a trained professional. So it's important to note that substance use treatment is different from sponsorship. For example, in the 12-step or Alcoholics Anonymous traditions, or peer support, in which somebody who has had the same condition provides assistance and support. Sponsorship and peer support are great, and they definitely have their place out there as people are trying to recover from substance use disorders. But sponsorship and peer support do not require the same level of skill and training as doing clinical work. It's the severity of the substance use disorder that dictates the need for specialized care from a trained professional, usually after there have been multiple attempts to control or treat the substance use disorder without clinical treatment, and it's failed. So again, the severity of the substance use disorder usually dictates whether or not somebody needs to enter a substance use treatment facility. If somebody has a more mild substance use disorder that is causing problems and negative consequences, they may really benefit from having a sponsor or talking to a peer who has gone through similar scenarios. But typically the clients we see in substance use treatment have tried that or some variation of that, and it hasn't worked for them. So an example of this would be thinking of a person who develops symptoms of an illness or getting sick. So you first start having symptoms, you're not feeling very good, maybe you're getting congested in your head and you're developing a mild cough. And so often what people will do is ignore it at first and see if it goes away. And then if it doesn't, maybe you try talking with a friend who had similar symptoms last week and see what happened to them and how long it took and what they did to try and solve that. And then maybe you try over-the-counter medications. You go to a local drugstore and you pick up some NyQuil or some variation of that and you see if that works. And then when none of that works, then you go to the urgent care facility and you see a doctor because things aren't getting better. And at this point, you need someone who can provide specialized care. That is exactly what typically happens when somebody has developed a moderate to severe substance use disorder. At first, when the substance use disorder starts, or the substance use starts causing problems, the person may try to cut back or limit their substance use. They tell themselves, all right, I'm only going to have 2 drinks. That's it. Then I'm going to go home. And then they find that they can't cut back or limit substance use. Even with the best of intentions, they end up using more than was intended. They may ask a friend to try and hold themselves accountable. Hey, please don't let me drink too much, when we go to the party this weekend. And if that doesn't work, maybe they try an Alcoholics Anonymous meeting or a number of them. And if that doesn't work, they may try to work with a sponsor. And then if that doesn't work, then they may enter a substance use treatment facility. So in California, the certified alcohol and drug counselor is required by law to receive training and demonstrate competency in the clinical skills needed to treat substance use disorders in clinical settings. So this includes specialized skills in assessment, diagnosis, planning, and targeted interventions, which will be based upon the patient or the client's individual needs. And those needs are dictated by the specific and particular nature and circumstances of their substance use disorder. So the first lesson in developing clinical skills is to develop a clinical mindset. A mindset is a way of thinking. It's a set of assumptions or methods or notions or an attitude or an established set of attitudes that you use when approaching any kind of a situation. So a clinical mindset are a set of assumptions or a mental attitude or set of attitudes that you use when approaching a situation in a clinical setting. So I have a feeling we're not in Kansas anymore. So step 1 to developing a clinical versus judgmental mindset. A judgmental mindset is one in which you form an opinion and categorize or define another person based on an arbitrary standard. What I mean by that is that you, when you're judging someone or when somebody's being judgmental, they have some standard in their mind of this is okay, this is not okay. And then what they do is they categorize that person or define that person based on that. This is good, this is bad, this is right, this is wrong. This person's an addict, this person is a normie, this person is a jerk, this person is awesome. So a judge typically performs a judgment or passes a judgment as a final authoritative statement or decision about another. So when we judge someone, usually what we're not doing is seeing their behavior in a spectrum that could continue to develop. We're making a statement about who they are. He's useless and he's never going to change is a judgment. She's such an angel is a judgment. There is something wrong with that kid is a judgment. He's a terrible father is a judgment. So you notice in these judgments, there's no attempt to try and understand why the person is that way or how this developed, and typically doesn't even leave space for that to change. So looking at someone and saying, he's a terrible father. It is a definitive authoritative statement about a person. Now, humans are inherently judgmental. If you think you're not judgmental, you're wrong. It is normal for people to be judgmental when they're not at work. It's normal for clinicians to be judgmental when they're not at work. And in fact, being judgmental is the default way of looking at things. What I mean by that is that the human brain tends to do this. The human brain works with these mental shortcuts, sometimes referred to as heuristics, which is taking a quick view of a situation and then making a snap decision about what our perception or view is of that situation. And humans do this. They do this very quickly. They see something and they make a judgment. You walk into a new place that you've never been before. You're meeting a friend in some area of downtown and you park your car and it's a neighborhood you've never been in before. You won't be able to stop yourself from judging how safe you feel, for example. If you're looking around and street lights are out and there's some sketchy looking characters over there in the corner and you hear somebody fighting in an apartment up above and your body may go like, whoa, what's going on here? This feels a little wary. Or you may step out of the car and you're in a place there's a lot of people and they're all having fun and it's well lit and there's a street fair going on and you're like, oh, cool, this looks like fun. I'm glad that I'm there. This all happens normally as a default way of approaching things. And there's some evidence from biological psychology studies that forming these kinds of quick judgments and acting on these judgments may be an inherited survival strategy. Back when humans were living in a much more dangerous world than we're living in now, sometimes that ability to pass judgment fast and then make decisions may have meant the difference between surviving a situation and not surviving a situation. So having this judgmental mindset as a default, when a person with a judgmental mindset looks at a dysfunctional family system, for example, they may look at this and say, oh my God, this family is fucked up. Or I can't believe he lets her treat him that way. What is wrong with her? He's an idiot. Oh, hell no. Any kid who talked to me that way to get the back of my hand. What a brat. She's totally enabling him. While these kinds of judgments may be a normal default way of looking at things, this is not helpful when doing clinical treatment. A clinician needs to instead develop a clinical mindset. And so having a clinical mindset does not categorize or define somebody based on a standard and then stick that person in that category and leave them there. A clinician's job is to try and understand why a person or a family system is thinking or feeling or acting in a certain way and how this is affecting the person and the others around them. So instead of looking at the 12-year-old in the family system who's acting out and throwing things and not listening to his parents and going, God, what a brat. Thank God my kid's not like that. That's judgmental. A clinical mindset instead would try to understand, well, why is this child acting this way? Why might he be doing that? What are the situations and circumstances that might have led to this? How is this impacting his parents and their emotional state? Does this family need help? Are there missing skill sets? Does maybe the child have some kind of a psychiatric condition that's causing him to act out that way? So a clinical mindset is to attempt to try and understand without judgment why something is happening, how it's impacting whatever the situation is, and what we can ultimately do about that. So that requires suspending judgment. Now, particularly if somebody is doing something, a person or a family member, if they're doing something that we think is wrong or dramatic or stressful or stupid or counterproductive or maladaptive, we can't go into our default way of looking at things. The real challenge in maintaining a clinical mindset is when somebody's doing something that is against our values or our morals or our ethics or beliefs about how a person should think, feel, or behave. That's exactly when we need to work to make sure that we're not being judgmental and instead we're open to try and understand what's happening with that person. And that requires training. Clinicians don't just naturally become clinical and develop this Zen-like ability to just approach things openly with curiosity. That requires understanding the difference between being judgmental or clinical and practicing this in many different ways. In the AODS program at San Diego City College, our clinical courses introduce students repeatedly to clinical scenarios in which they will be tested. And many of those scenarios may trigger the trainee clinicians where they may feel judgmental about what's happening or respond in a judgmental way. And what we do is we help train them not to do that and instead to maintain a clinical mindset. So with a clinical mindset, we are trying to understand a person or a situation as it presents itself with openness and acceptance and curiosity. Remember, a judge passes judgment. A judge defines what they see based on some standards, as it's either this or it's that, and then usually what happens is we're done with it. Whereas the clinician is going to be open to what's happening, accepting of what's happening, and being curious. So if a client that a clinician is working with, suddenly comes, so if I'm working with a client who comes into my office and they're like, you know what, screw you, Keith, I think you're such a jerk and I really hate you, and what you said to me earlier on today was totally unreasonable, and I don't want to work with you anymore. So a judge may look at that situation and say, like, God, who is this person? They don't understand what it is that I'm going through. They're being totally unreasonable by barging into my office and telling me they don't want to work with me. And you know what? We don't transition people to other counselors anyway. And so my response in that judgmental way may be, excuse me, if you have something you need to say to me, you can knock on my door before you come in. And I've already decided in my mind, this person's a pain in the ass and I don't want to hear what they have to say. Whereas having a clinical mindset is accepting what's happening in front of me with openness and curiosity. So in this different response to a situation like that may be me saying, okay, wow, like, what's going on? You sound like you're really, really upset with me. I want to hear about this. Why don't you come in and let's talk about this? So you said you feel like I'm being a jerk in some way and you didn't like what I did. Tell me more about that. I'm not sure exactly what it is that you're referring to. And why do you feel like you might be able to work with somebody different? So I'm trying to understand what is happening in the situation. I'm trying to assess it. Try and understand any antecedents or things that might have happened before this situation developed and how that might have impacted why this person is being the way they are. I'm going to try and understand how this situation is affecting the person and others who might be peripherally involved in this. And then when appropriate, a clinician will attempt an intervention to try and be helpful and improve the situation if it appears to be maladaptive or problematic and or causing stress for a person. When working with families then, a clinician will look at a dysfunctional family system and think to themselves, why is the family acting this way? Is this behavior helpful or is this behavior troubling? How did this dynamic develop in this family system? And where can we make adjustments and bring something to awareness or maybe learn new skills? Ultimately, how can I help rather than deciding, whoa, these people are totally messed up and I don't know what I'm going to do with them. Addressing relational dynamics in clinical work requires having the clinical mindset, but also understanding that relational dynamics are patterns of interacting, or relating with other people. A relational dynamic includes patterns of communication. So a pattern of communication may be dominating other people. When looking at a family system, the first time that I meet the family, they all may walk in the door and I say, hi, thank you all for coming. And immediately mom launches into, yeah, well, it almost wasn't going to happen. You know, the kids, oh my God, my eldest is such like a terror, didn't even want to come. And they don't understand how important this is to support, you know, the brother while he's in treatment. And I'm listening, yeah, okay, well, great. Well, I turn to then the children and say, so what happened this morning? I'm wondering if maybe you all were feeling like you didn't want to be here today. And mom cuts in and says, well, yeah, they didn't, but I told them that they had to come. Well, that would be a pattern of communication in which mom is dominating the relational dynamics or the ways of acting or interacting with other people. Maybe the 12-year-old doesn't say anything. The 12-year-old is sitting there with his arms crossed or her arms crossed, and I'm asking questions and I'm getting shoulder shrugs. That would be withdrawal. That's a pattern of communication. Aggression can be a pattern of communication. Relational dynamics also include perceptions between people, emotional expressions, and ultimately how they act with each other. This includes formal patterns represented by social, cultural, family rules and roles, What I mean by that is maybe the person comes from a culture in which the father is expected to speak first for the family system whenever interacting with a professional of some sort. So that would be a formal pattern of relational dynamics dictated by a social cultural family role. It also includes informal patterns, such as alliances that may form in a family system. Maybe two of the siblings have formed an alliance. They're super close with each other. They share things with each other they don't share with anybody else. Or power hierarchies in the family system. Maybe the eldest daughter has really aligned herself with the parents and is constantly saying things like, oh, my sisters and brothers cause so many problems for my mom and dad, and I just don't know what's gotten into them. I try to tell them to be much more respectful, and they just don't listen to me. That would be a power hierarchy in which the eldest child is trying to align herself with the parents and the power associated with that. And then relational dynamics also represent particular dynamics that emerge in specific instances, meaning that maybe this dynamic isn't there. Maybe the aggressive style, or let's say defensive, that's a good example. So if somebody's defensive, they may not be defensive all the time, but let's say I'm defensive and my wife says to me, honey, hey, would you mind making sure that you put the cover on the garbage because it's summertime and the flies are getting in the garbage? And I immediately respond and say, what? I wasn't the last one that was in the kitchen. Maybe you're the one that didn't put the cover on the garbage. Like, why are you blaming me for that? So that defensiveness or that pattern of communication arises in any specific instance in which I feel like I'm being judged or told what to do or some reason need to defend myself. So relational dynamics encapsulate all these patterns of interacting with each other. So all clinical work is going to address relational dynamics in one form or another, because anytime a person is interacting with another person, there are relational dynamics that are influencing that exchange. There are dynamics in family systems, patterns of how family members interact with each other. There are work dynamics, patterns of how you are with people that you work with and how the people who you work with act with you. Those work dynamics are typically different than the dynamics that you may have at home. There are social dynamics that come into play. When you go over to your sister and brother-in-law's house for a Christmas party, there's social dynamics that people fall into. I mean, typically, things like introducing people to other people. Oh, hey, I'm sorry. Let me introduce you to my friend Joan. My friend Joan's also a counselor. Oh, really? Where do you work? There's almost a script or a pattern of communication that happens when we get in social settings. There are friend dynamics, typical ways that we interact with our friends. There are enemy dynamics, typical ways we interact with our perceived enemies. Couples have dynamics, parents and children have dynamics, groups have dynamics. Anytime that a group gets together, there's some typical dynamics that emerge. One example in a group is that anytime there's a group of people together, one or more people will attempt to lead or influence the group, the conversation, what's happening in that group. There is almost always some people in groups that will withdraw and not respond or follow or wait to see what others are doing. In group dynamics and substance use treatment facilities, we see these kinds of roles emerging all the time. And many times what we're seeing is that the dynamics happening in the substance use group are typically the same types of dynamics that are emerging in the outer world realms. And then there's counseling dynamics, meaning that there's a dynamic between the counselor and the client in terms of how they're interacting with each other and exchanging. For substance use disorder clinical work, relational dynamics have a huge influence in both why somebody uses substances and what will stop them from using substances or reduce the harm from using substances. What I mean by that is that relational dynamics can be positive influences. So the dynamic between counselor and client, or positive relational dynamics with supportive family members or sponsors or support groups, may influence why somebody seeks treatment and help that person from using substances after they leave treatment or relapse prevention planning. At the same time, relational dynamics sometimes are negative influences. Many times we see with people who have substance use disorders that there are enablers or a pattern of enabling that goes on that allows a substance use disorder to continue. Maybe there's a relational dynamic in which a person provides substances. This could be the drug dealer, of course, but this also could be that every time you go over to your aunt's house, she immediately gets you a drink. And now you've been to treatment for an alcohol use disorder, and this negative influence is a problem because your aunt doesn't really think that treatment is a legit thing. She doesn't understand why you do that. You still have a job after all, right? So I don't think you've got a drinking problem. And when you go over to your aunt's house, she's still trying to push alcohol on you. So that would be a negative relational dynamic. Sometimes relational dynamics are sources of stress, and the stress itself is a reason why somebody was using substances or may continue to use substances. Throughout the Alcohol and Other Drug Studies program here at San Diego City College, students learn much more about relational dynamics and substance use treatment, both in the family counseling class and in the group counseling class and in many of the other counseling classes that the student will take. Let's add in the golden thread to the clinical mindset. With a clinical mindset, we are approaching relational dynamics with openness and acceptance and curiosity. The work we do as counselors in healthcare professions can be captured in the medical treatment model that's often referred to as the golden thread. The golden thread links three things together. The first part of the thread is always to assess what's happening. So if we don't know what's happening, or if we haven't assessed why something is being caused, then we don't know how to treat that. If I go into my doctor's office and I say, "Oh, doc, I have this back pain. It's killing me." The doctor doesn't say, "Great, here's a prescription to go to the chiropractor, see you later." Doctor's going to say, "Wow, okay, tell me more about that. What's happened to your back? How did you hurt it? When did it start?" So assessing what is happening and why. That's always the first step. So the assessment then leads to the plan. Okay, now that we know what's happening, now we can develop a plan on how to address what we assessed. So if I come into my doctor and I say, "Oh God, doc, my back is killing me. Like, oh, I need help." And the doctor says, "Wow, well, what's happening?" And I say, "Oh, I was working on my deck, and I slipped and I fell on a nail, and the nail is still here in my back. See, look, it's poking out of my back, and I didn't know what to do." Well, then, okay, the doctor is going to say, "Wow, okay, well, it sounds like the pain's being caused from a nail in your back. So the plan would be we need to get that nail out and see what else is going on. So let's first make sure that we disinfect the area around where the nail is, and maybe we put some gauze around it, and then I'm going to pull on this nail and see if it'll come out." And that would be the plan. Whereas if I came in and I'm like, "Oh God, my back hurts," and the doctor says, "Wow, why? What happened?" And I say, "I don't know. I was totally fine. And then I bent over and I tried to pick up this really heavy box. And then I had this like searing pain that just ran through my lower back." Doctor's going to say, "Okay, so it sounds like you probably threw your back out, and there could be one of two things that are happening, or maybe even more. You may have created a muscle strain of some sort, or it's possible that you might have misaligned one of the vertebrae that are in your back. So maybe what we should do is first see if ice and heat helps, and then if that's not helping, then maybe I'll give you a referral to a chiropractor." So you see how the plan is very different depending upon what we've assessed. And we plan before we take action. That's part of the medical treatment model. Also, we don't want to go off half-cocked and just making interventions and doing decisions before we've carefully assessed what the situation is, come up with a plan, addressed any possible variations on that plan, and then we implement whatever the treatment model is. So that's called the golden thread. When we're using the golden thread, when doing clinical work, whatever the presenting issue is then, first and foremost, we need to assess. So in assessing, we are going to try to identify, first of all, what specifically is the issue? What is the dynamic, or what is the thought or the feeling or the behavior that the person's presenting with? If we don't know what the problem is, then we certainly don't know how to plan to intervene based on that problem. So we have to figure out first what it is. Now, once we know what the problem is, let's take a simple one as an alcohol and drug counselor. So what is the problem? The person cannot stop using alcohol. And that's why they're in substance use treatment, because their family has had it. They did an intervention. They told them, if you don't go into alcohol treatment, then you can no longer stay here in the house any longer. So we know that there may be many problems, but one what of what the problem is the person's using alcohol in a problematic way, and they appear not to be able to stop or control that. Then what we're going to do is look at why. So we need to understand, why might it be happening? What are the factors that have led to the problem? Going back to the example I gave about back pain, so the doctor may look at me and say, the problem is Keith has back pain. Why does Keith have back pain then becomes an important thing for us to try and explore. Keith has back pain because he has a nail in his back, or Keith has back pain because he tried to lift a heavy box and he didn't use proper ergonomics, or whatever that word is. So in finding out why something might be happening, we need to ask and hypothesize and interpret and explore and discuss with the people or person who has the problem to try and figure out, how did it develop. The other thing that we do when we're assessing is to assess, well, how is this affecting the individual or the others? So when I come in with a back pain and the doctor asks me, like, well, what happened? Oh my God, I fell down. I had this nail in my back. Okay. Is it affecting your movement in any way? No, it just hurts. Are you able to turn your, yeah, I can turn, I can bend over. It just really, really hurts and I can't get this nail out. Okay, got it. If I came in and I've thrown out my back from lifting the heavy box, well, what's the problem? Back pain. Why is the problem there? Tried to lift a heavy box, didn't use proper form. How is this affecting you? I'm in massive pain. I'm totally bent over. I can't straighten up. Okay, so we're going to get all that picture together in our assessment. Then we're going to come up with a plan to address what we've assessed. In substance use treatment, plans to address concerns are captured on a treatment plan, which the student learns more about in the AODS program. And once we've made a plan and we've addressed any possible problems with that plan or any other factors that need to be considered, then we intervene or take action. The word intervene, or a clinical intervention for the work that we're doing, means that the counselor clinician is doing a deliberate action or non-action. Sometimes using silence, for example, is a clinical intervention where we just wait for somebody to answer their own question, come up with their own solution. Maybe we're making space for them to just feel an emotion that they haven't felt before. So a deliberate action or non-action, but it's deliberate, that the counselor's doing to try and influence a person or influence their perception or influence an expression or awareness or a feeling or a relational dynamic. So we're doing something deliberately to try and influence whatever the situation is with the goal of trying to improve that situation. So here's an example scenario. Let's take this example scenario and look at it from a judgmental mindset, and then look at it from a clinical mindset utilizing the golden thread. The scenario is you're about to meet with your client and her husband to discuss relapse prevention planning for when she graduates from the substance use treatment program and moves back home in 2 weeks. 5 minutes before your session, you hear shouts and arguing coming from the lobby waiting room. You go out and your client and her husband are screaming at each other in the lobby. The husband picks up his bag of to-go fast food and he throws it at your client, spraying soda and French fries and burger fixings all over the lobby. You notice there are other clients there, they're all looking at the drama, and then they're looking back at you to see, what are you gonna do? So that's the situation. Here's the relational dynamics. The judgmental mindset, the judge will look at this situation and think, what the fuck is wrong with you two? God, they need to get a divorce. They are total morons. This is never going to work. Oh my God, I'm embarrassed and I'm ashamed that this is my client. Or maybe they may even think euthanasia perhaps should be a legal option in situations like this. This is not helpful for doing clinical work. We need to suspend our judgmental mindset in spite of what we may initially think about this acting out that my client and her husband are doing, and instead approach it from a clinical mindset. In a clinical mindset, utilizing the golden thread, I would first look and try to assess, okay, what exactly is happening here? Now, this is going to go on pretty fast in your mind, but we need to identify, well, what's happening? All right, what's happening is my client and her husband are arguing and now food's being thrown. They're both severely emotionally dysregulated. Their actions appear to be out of control, and this situation is moving towards potential violence. In addition, there's some other clients who could be harmed in this situation. So that's what's happening. The clinician then may, in the moment or shortly after that, need to try and figure out, well, why are they acting this way? So what's going on? Something must have happened. Maybe there was an argument or some other major stressor that led to this. My client and her husband may have poor assertiveness or conflict resolution skills. This might be a domestic violence relationship that I wasn't already aware of. Or maybe there's some lingering tension from an earlier argument or issue. I need to assess how this is affecting my clients and the others. So as I'm looking at the situation, I see what's happening is this massive argument. Why it's happening, I'm not sure, but I could hypothesize something happened that led to this, and it appears that they don't know how to handle it. So how is this affecting my client and the others? Well, I can see that there's a lot of anxiety and anger. This anger is escalating and it's leading to things being thrown. They're going to have a really hard time focusing on relapse prevention, which is the whole point of the session we're supposed to be having. And this could potentially endanger other clients, and my client may not want to go home anymore. So I've assessed what the situation is. Now I need to come up with a plan and figure out how I'm going to address what's happening in the moment. A plan should always consider immediate, medium, and long-range planning. So the immediate thing that I'm thinking I need to do is I need to ask them to stop throwing things and yelling at each other. And I'll try to separate them perhaps to opposite sides of the room. And if I can get them to calm down, then I'll bring them back to my office and I'll try and figure out what happened. But there's a bunch of other clients here that I'm going to need to account for. So I think I need to ask somebody for assistance with all of the other clients. Okay, now I'm going to intervene. Now, obviously, this happens quickly, and a skilled clinician may do this all in a second or two in their mind. Sometimes a brand new trainee intern might see a situation like that and freeze because it overwhelms the mind. Oh my God, I don't know what to do in this situation. But the trained clinician will quickly assess what's happening, quickly plan, is there anything that I should think about in terms of what I'm about to do, and then they're going to intervene. And so the intervention in this case may be to put the plan in action. So there are a couple of things that could happen. I might turn to another client and say, please go get the supervisor on duty and ask them to come up here right away. And then I step into the lobby and I say, whoa, hey, please stop throwing things. I need you both to calm down. Can you please step away from each other and just move over to the sides? If they do that and they step away from each other, like, okay, so wow, let's take a deep breath and let's go back to my office. Do you two feel like we can do that? And then I take them back to my office, and now we move into the more intermediate and long range planning. So this is an example of how to utilize a clinical mindset versus a judgmental mindset in a particular scenario. Now, in the alcohol and other drug studies program, those students who are taking the family counseling class would then have the opportunity to put this into practice. in part of the training that all of the AODS students get, they are introduced to clinical skills and clinical concepts, and then the students get the opportunity to practice those skills and concepts in a training setting, in a protected setting, in preparation for demonstrating competency and ultimately for passing the state exam to become a certified alcohol and drug counselor. All right, so that is an introduction to clinical work and relational dynamics. There will be more to come in additional lectures on how to handle working with families and how to handle working with groups.